Good morning. We've got a packed house this morning. I'm B.R. Dobbin. I'm the course director of Geriatrics and Palliative Care Grand Rounds. It's my privilege to welcome you here this morning as we continue our Palliative Care and Geriatric Fellow series. Today I'm introducing Leslie Cartagena. Leslie is a board-certified family nurse practitioner through the American Association of Nurse Practitioners. She completed her Bachelor of Science in Nursing at the University of Massachusetts, Boston, and then earned her Master of Science degree at the University of Massachusetts, Lowell. After graduating with her master's, she worked for a nonprofit hospice agency as a nurse practitioner where she found her passion for helping those with life-limiting chronic illnesses. Prior to this, she was a registered nurse here at MGH on a medical oncology floor for 5 years. I think some of her friends are here to see her this morning. Leslie has volunteered for a medical mission brigade providing primary care to those in rural villages in Juticalpa, Honduras. Her interest is serving those in underserved communities and overcoming health disparities by breaking socioeconomic barriers that prevent access to care. Please join me in welcoming Leslie.
Hello, everyone. As VR mentioned, my name is Leslie Cartagena, and I'm a nurse practitioner fellow here at MGH as part of the Harvard Interprofessional Palliative Care Fellowship. Today, I'm going to be talking about something that's very important to me, both personally and professionally. I will be talking about Latinos and palliative care. The title of my discussion is ¿Qué es el cuidado paliativo? What is palliative care? Explaining palliative care to Latino patients with advanced illness. My objectives for you today are to examine one's own biases in caring for those from cultures other than your own, to identify barriers that prevent Latinos from receiving optimal palliative care consultation services, and to distinguish which cultural beliefs and practices will guide decision-making in the Latino population with advanced illness and at end of life. I have no pharmaceutical or financial disclosures, but I do have to disclose that I am Latina. Yo soy Latina, yo soy puertorriqueña. I am from Puerto Rico. And I tell you this because identity in the Latino population is so important. And I have my own perspectives on this topic and may not be representative of all Latinos or all medical professionals in palliative care. So I hope that you all can learn a little something today on my own perspective and lens, and hope that you can apply what we learned today and share with your colleagues. That's a picture of me and my family, my grandma in Puerto Rico. As a nurse on Allison 16, I would speak Spanish to my patients, to my Latino patients. And when they heard the language come out of my tongue, out of my mouth, they would say, ¿De dónde eres tú? Where are you from? And I would reply, Yo nací y me creí aquí en Boston, pero mis padres son de Puerto Rico. I was born and raised here in Boston, but my parents are from Puerto Rico. My parents came in the late 70s. My mother, highest level of education is 4th grade. My father completed high school. I'm the first one in my family to go to college. I grew up in a Spanglish-speaking household where we would mix both English and Spanish in the same sentence, or they would speak to me in Spanish and I would reply in English. I tell you this because acculturation and Latinos vary. And identity in the Latino culture, as I mentioned, is so important and very individualized. I think we, as a fast-paced Western medicine culture, feel comfortable with categorization, and we love our checkboxes because it makes our job easier. But when we're caring for patients of different cultures, it's important that they're not all the same. Latinos are not a homogeneous community. We are not a monolith. This is what makes our community so rich and so vibrant, but also challenging when taking care of us. Acculturation is the ability to adapt to another culture, which also varies cross culturally. You can have a Colombian arrive from the US within a year ago who knows English and Spanish very fluently, or you can have a Dominican woman come from the Dominican Republic over 10 years whose English is limited and she feels embarrassed to go to the doctors. You can have a young third generation Mexican American who grew up here in the United States who barely knows Spanish. This level of acculturation makes a big impact on decision making, especially when we're talking about patients with advanced illness and at the end of life. You see these names on your patient list: Juan Rivera, Mercedes Rodriguez, Carlos Hernandez. What are the first thoughts, questions that come to your mind? And this one's my favorite. Excuse me. The American Journal of Public Health did a research study that showed approximately 2/3 of primary care providers demonstrated implicit bias against Latinos, even though they expressed egalitarian or unbiased attitudes. My goal for you all is to feel empowered to ask your patients questions about their background in a culturally sensitive way. When it comes to cultural humility, there's great power in acknowledging your own lack of understanding. So, this is a judgment-free zone. Excuse me, I'm getting over a cold. This may seem obvious to some and completely obscure to others, but it's important that we all know the basics. Latino, the term, refers to people of Latin American origin. So this is a map of Latin America. This includes Brazil and Haiti, but excludes Spain. So when we talk about Latinos, we're also including Haitians and Brazilians. When we use the term Hispanic, it focuses on the Spanish-speaking origin. This means Spain is included, but excludes Brazil, as they speak Portuguese, and Haitians as well, who speak Haitian Creole. We're also seeing a new term, the term Latinx, which refers to the gender neutral Latin Americans. In the literature, these terms are often used interchangeably. As I mentioned before, Latinos are not a heterogeneous genius, are genius and a diverse group of people. The ethnic heritage of Latinos is a mixture of indigenous, European, and African cultures. For that reason, cultural practices and traditions, physical appearance, indigenous roots, political and social and economic histories are very distinct from one another. So things to consider when you're thinking about your Latino patients are the duration of time that they've been here in the US, as this affects acculturation and the use of services, the timing of when they arrived, as socioeconomic and political atmosphere in their country, as well as here in the US, can affect their use of services. Generation differences are also significant, as the younger generation may find it easier to assimilate to the culture, while older generations may be stuck in their old ways or have a harder time learning the English language. Latinos are the largest and one of the fastest growing minorities in the United States. Latinos are expected to comprise about 30% of the US total population by 2060. It should be noted that cancer is the leading cause of mortality and morbidity in Latinos. Cancer accounts for 21% of deaths in Latinos, followed by heart disease. For this reason, I suspect that we'll be seeing more Latinos coming through our doors. This is a segment of the annual report on equity and healthcare equality here at MGH. It displays the percentage of MGH inpatients and outpatients by race and ethnicity. As you can see, inpatient numbers for Hispanics are at about 8%, but there's a light blue shade there that represents patients that are being seen at other facilities in the area. And then we also see a significant amount of Hispanics being seen in the outpatient setting at around 21%. The report notes that these Latino patients are not being seen here on the main campus, but they're being seen in the health centers in Everett, Revere, and Chelsea that have a substantial, large Latino population. This raises two questions for me. Where are Hispanic and Latinos going for inpatient care? And as the Latino population grows, specifically with cancer, are we ready to take care of them? Most of us are aware of the health disparities that affect minority patients and the constant effort to help transform our nation's healthcare. Language barriers are often most notable when we're thinking of patients who come from a different background. I'll get into this more in detail in the next slide. Health literacy is also a big one. Health literacy is the degree to which individuals have the capacity to obtain, process, and understand basic health information and services need to make appropriate health decisions. Prevalence of limited health literacy is higher among Spanish-speaking patients compared with English-speaking patients. Socioeconomic factors also are barriers. Hispanics are more likely than whites to work in agriculture, construction, domestic and goods services, and other low-wage jobs, which are less likely to offer employer-based health insurance and paid work leave. So when we think about our inpatients who are Latino and they really just want to get out of the hospital, they might have to work. They have to support their families because there's no paid time off. And as I mentioned before briefly, implicit biases by providers and discrimination and mistrust faced. Language barrier goes far beyond translating from one language to another. Language is so complex. There's not a direct translation for every word in every language. Sometimes the same word may convey a different meaning to those who speak the same language, but are from different countries. You see this with the direct translation of esperar, to hope, which also means to wait. So when we're having goals of care discussions about hopes and worries, we can see that there might be a little disconnect. What are you hoping for might literally mean, what are you waiting for? So when they give us an answer, you know, they're waiting for something specifically, even though we think hoping as in best case scenario, but they're really waiting for this. Even though Spanish language is the unifying original language for Latinos, not all Latinos speak Spanish or speak the same Spanish. Some Latinos even have trouble understanding the Spanish from another country. Some areas have their own dichos or their own sayings that might not be used in another country. Excuse me. One literature review showed that even when providers understand the benefits of using professional interpreters and they're readily available, providers all across different settings in the hospital have consistently used professional interpreters for less than 20% of patients with limited English proficiency. Despite the large body of literature that demonstrates the positive impact of professional interpreters and their outcomes on limited English proficiency patients, and also the vast literature that explains the detrimental impact that untrained interpreters have, this review showed that untrained interpreters were still commonly interpreting in palliative care. Family members were often used as interpreters to deliver information about prognosis, diagnosis, and assess symptom management for limited English proficiency patients at the end of life. Now, we've all encountered this situation, and I'm not here to throw any blame, but I think it's important that we're aware of this and how this can really impact our patients' care. Some of the reasons is that we don't have the time. There's some times where it's clinically urgent that we need to have it right here, right now, or the complexity of the conversations. Sometimes providers don't feel like it's less human if you have a third person in there, especially a machine like iPod that's translating over the phone. The most important thing I want to highlight is that even though patients can speak English quite well, they may prefer to speak Spanish or a language of their origin during times of stress or health crises. I've seen this multiple times in patients at the end of life. Last week, I had a gentleman with metastatic cancer whose English was fairly good. He was able to communicate his symptoms, but when I told him I spoke Spanish and I spoke to him in Spanish, the floodgates opened. He told me the specifics of his pain. He was able to tell me that he didn't feel like he really understood what was going on. And when I asked him about his understanding of his illness, he wasn't aware that he had metastatic cancer. A landmark study in the Annals of Internal Medicine that looked at pain and treatment in minority patients with cancer found that 65% of minorities did not receive guideline-recommended analgesic prescriptions, compared with 50% of non-minority patients. Specifically in the study, it showed that Latinos particularly reported less pain relief and had less adequate pain medication. Latinos also reported more concerns about taking too much medication and were worried about medication side effects and believed they needed more information about pain management. So when I think about this in our setting, sometimes we do have to go back and tell the patient what exactly we're doing. What medications are we giving at exactly what time, as they feel like they need the information. Another article that looked at racial and ethnic differences in advanced care planning among patients with cancer showed that Latinos were less likely to have a living will, medical durable power of attorney, or a DNR order, and less likely to acknowledge they were terminally ill. Hispanics were twice as likely than whites to prefer life-prolonging care. And Hispanics at 42%, compared to non-Hispanic whites at 14%, wanted their doctors to keep them alive regardless of how sick they were. This is the story of my uncle, a 63-year-old Latino male, a past medical history of diabetes, hypertension, obesity, substance use disorder. We as a family noticed that his appetite was poor and that he was losing a significant amount of weight in a short period of time. We thought something was wrong, but he was a man that avoided going to the doctors. I remember one time he came to the house, asked me to check his blood pressure, 200 over 100. And even if he went to the doctor, he didn't want his family to know anything was wrong with him. He rapidly progressed, and he didn't want chemotherapy, and we saw this decline. But our family, we really didn't know what was going on, and to be honest, I don't think he knew what was going on with his body either. He grew up in Puerto Rico. He came to Boston in the 1970s. He grew up with 15 brothers and sisters, has 8 adult children, lives in public housing, and at that time, his adult daughter, who was a paraplegic, was living with him. And he was taking care of him. And he was taking care of her. One night, he was experiencing shortness of breath, and that was very startling to him and his daughter who was staying with him. He was already enrolled in hospice at that time, but his daughter's first inclination was to call 911 to have him receive immediate help. While in the emergency department, she sensed frustration from the medical team when they found out that he was enrolled in hospice. She said, "I just wanted him to be comfortable." He was found to have septic shock, secondary to pneumonia, and admitted to the ICU for antibiotics and pressure support. Daily, the team would come in wanting to change his code status to DNR/DNI. She would tell the team, if you could save him, then do it. Do whatever you can to keep him living as long as he can. My family, in all honesty, had a real hard time understanding what CPR meant in patients with cancer. And after multiple attempts, he was made a DNR/DNI, but he declined very rapidly in the ICU. And he needed IV opioids to manage his symptoms, his shortness of breath, and he eventually passed away within days. We'll get back to his stories in a little bit and discuss the barriers and the values that I was able to take away. There are 6 values that have been studied as common themes when looking at decision-making in Latinos. And I would note that a few of these values really come into conflict with values of individualism, self-determination, and autonomy, which is prevalent in Western cultures. As we move along, I want you all to reflect on a case of your own where you took care of a Latino patient and see how these values played a role in their case. Familism is, excuse me, is the social structure where the needs of the family are more important and take precedence over the needs of any other family member. It also involves families' advice for very important decisions. Latinos tend to have larger families compared to non-Latino whites. According to the U.S. Census Bureau, Mexican Americans have the highest percentage of families comprising of 4 or more people compared to other Latino groups and non-Latino whites. Latinos will also often call people who are not their immediate family or distant family, they'll call them their family members. So godparents, godsisters, godbrothers, or people who are very close family friends, that they consider them family members and also want them to be involved in decision making. In one article that looked at the role of families in decision making about cancer treatment, non-English speaking Hispanics reported sharing decisions with family more frequently than English-speaking Hispanics and whites. And Latinos were more likely to defer to their families to make decisions about hospitalizations and ICU care, whereas non-Hispanic whites were more likely to allow the physician to decide. You can imagine that time-sensitive medical decisions may be delayed to allow the consultation for the extended family. So, familismo, ¿qué podemos hacer? And throughout this whole entire presentation, you will see me quote, ¿qué podemos hacer? Which is, what can we do? Ask your patient how much they want to know and normalize deferred decision making. Ask patients the role they would like their family to play in their care and allow patients to decide who is a member of their family. Actively engage family members and allow the family to be in the care, especially in the care of their dying loved one. Identify a spokesperson for the family and communicate any changes or needs. Designate a space where the family members can congregate. As I mentioned before, Latino families are often larger and they will congregate in the room together. And this can be difficult when you have a shared patient room or you're having really complex care discussions. So if you can use the hallway down the, if you can use the room down the hall, I think it's important that, you know, we really take the time to do that, to designate that space. I also want to mention that at the end of life, when family members pass away, Hispanics can also be very emotional and very expressive. And so if you have that designated place to bring family members to that room, it would be very helpful, not only to them, but the rest of the staff and patients who are on the floor. It's also important that we make the time to meet with the whole family to answer any questions and offer referrals and provide resources to anyone in the family who may be experiencing significant difficulties. Personalism, personalismo. When establishing relationships with professionals, Latinos require rapport building that includes warmth, informality, and regard. Personalismo is a value that places considerable emphasis on personal interactions of people. Latinos want to be liked. They tend to be relationship-centered and prefer informal and supportive interactions to formal and professional interactions. So showing affection is one expression of personalism. Don't be surprised if your patients want to hug you or they give you a kiss on the cheek while saying hello or goodbye. Personalism, ¿qué podemos hacer? What can we do? Communicate both verbally and non-verbally in ways that foster a harmonious interaction. So use warm communication, display attentiveness, look at them, use appropriate touch. I like this picture a lot because it shows the other hand on top of the other person's hand. So they're kind of just giving that really nice embrace. So I think this is something that we can do. If you don't feel comfortable hugging your patients, you can kind of do this and they can feel the sense of warmth from you. And I think it's also important that you are aware of your own boundaries. If you're not a touchy, huggy type of person, then that's okay. But I think it's, if you show compassion in the way that you communicate with patients, they can feel that, they can sense that. And the other thing is learning a short phrase in Spanish. I can't tell you enough the impact that just a little bit of Spanish has on the patient. And this goes for all languages. They really do appreciate it. Even if it's no hablo inglés, I don't speak English. I mean, no hablo español, I don't speak Spanish, sorry. But I think this is just so important in that, you know, they can feel that you tried. They'll laugh, they'll smile. And from that point on, you've already started the relationship really well. Respeto. The cultural value of respeto reveals the hierarchical structures that may exist in communities, which contribute to differential behaviors toward others based on a number of factors: age, gender, social or economic status. Latinos perceive professionals as highly regarded authorities who are not to be questioned, leading to misunderstanding or non-compliance. In one study that looked at qualitative factors to decision-making with cancer treatment options, participants typically asked their physicians to choose the specific treatment that would work best for them according to their cancer type and stage. Patients want a modest, paternalistic patient-physician relationship, contrary to the concept of patient's autonomy in Western healthcare. Even when Latinos do not understand, they may signal understanding to appear cooperative and not defy the authority figure. How many of us have taken care of a patient that just smiles and nods their head and have no idea what you're saying. I think it's important that we pick up on those social cues. So, ¿qué podemos hacer? What can we do? We can use formal titles, señor, señora, dama, caballero, and try to do your best to learn how to pronounce their name as they would. As I mentioned before with the short phrases, saying their name similar to how they would say it is very, very important to them. I think it's also important that we consult with their own respected authorities, traditional healers or religious leaders, their pastors, their priests. And along with the smiling and the nodding the head, I think it's important that we ask for their understanding of the disease in their own words. And also ask how much patients want to know and provide recommendations accordingly. Excuse me. Confianza, trust. With confianza, the sense of trust in the Latino community, individuals are invested in establishing relationships that are based on reciprocal trust. So experiences of discrimination, prejudice, and oppression can have detrimental effects on establishing trust. Understand that this might take time, especially for patients who weren't born here, who recently immigrated from a different country, and or have trouble managing the health system here. ¿Qué podemos hacer? We can assess our own level of understanding of racial and ethnic identity in order to understand the experiences of Latinos and other ethnic minorities. If a talk like this makes you feel uncomfortable, or if you sense yourself getting really excited, try to assess what are the previous experiences that you've had that make you feel that way. Understand that developing trust takes time, as it would with any other patient. And I think it's so important that we actively engage social work. Oftentimes, particularly with patients from a low socioeconomic status, they need help navigating the system. And often social work are the people who are helping them with getting letters for work or finding resources in the community. So when we pair up with our social work colleagues and present ourselves as a team to the patients, they can feel, wow, this person is on my side, they're a team, they're in my best interest. Another thing that I think it's important for us to do is to consistently follow through on promises, especially calling patients. Latino patients often are waiting for your phone call. If you say you're going to call them, they will or will not take a medication because they weren't told to, unless you specifically tell them to do something. The patient that I had last week that I mentioned, who knew English fairly well but felt more comfortable speaking in Spanish, he was constantly asking me through the interaction, is it okay for me to take this? Are you sure? Is it okay with my other medications? And so they need a lot of reassurance. And also, it's important that we address discrimination and prejudice. I think it's important that we, let our patients know that we're on their side and we're not here to judge or to make them feel uncomfortable, that we really care about them, and let them, ask them about their previous experience with the healthcare system. See if there's any mistrust that they may have felt before, so that we can address these situations up front, rather than finding later on that they didn't take a medication or they didn't want to come into the hospital because they sensed a feeling of discrimination. Dignity is the worry that worthiness is being jeopardized at the end of life, particularly surrounding the way they look, they dress, bodily functions, and the ability to eat. In my family in particular, we enjoy eating. And most of Latinos really have their social interactions surrounding food. So family members are often constantly offering food, sometimes force feeding patients who may find it hard to eat. But the patients themselves may not want to let their family members know that they don't feel like eating, because this is such an essential part of the culture. And also a sense of feeling like a burden to their family. Dignidad, ¿qué podemos hacer? I think it's important that we explain the trajectory of decline to patients and their families after asking for permission, and to allow them to exercise as much autonomy as they wish. In the specific situation with food, you can let patients and their families know, he might not want to eat, he may not feel like eating, so it's okay if he declines. And making sure patients are aware of that as well, that they can say no. Address specific fears and anxieties surrounding the end of life. And I've found it helpful in my own experience as a nurse to have same staff persons or family members to assist with basic activities of daily living. One of the more important things that I've come across in the literature is spirituality. And spirituality is very important and affects decision making at end of life all across cultures. In Tracy Balboni's article that looked at religiousness and spirituality and support among advanced cancer patients and associations with end-of-life treatment, preferences and quality of life, she found that most patients, regardless of ethnicity, consider religion to be at least somewhat important. African Americans and Hispanics rated religion as more frequently than whites. And patients are seeking deeper religiousness or spirituality at the end of their lives. Religiousness is often associated with wanting all measures to extend life, even after adjustment for race and ethnicity. Latino surrogates more often indicated that suffering was to be borne part of a test of faith to God. I've heard this several times, that está en las manos de Dios. It's all in God's hands. And I really want to highlight the importance of our spiritual care team in helping assess spirituality in all of our patients. They just do such an incredible job at asking questions. And I think it's important that we as providers, clinicians, align with them so that we can address any existential distress that's going on in their lives, especially with regards to spirituality. So ask about specific religion preferences. Not all Latinos are Catholic. In one JAMA review that talked about a specific case with a patient, there was a Protestant woman at her end of life, and they never asked her, but she was put in the system as Catholic. So a Catholic priest came in, and the family was kind of, what's going on? They were kind of, they didn't feel like they could align. So I think it's important that we don't always assume that they're even religious, for that matter. You can ask about church attendance or home religious groups or studies. Explore the patient's sense of control and belief in his or her own ability to alter the course of events. When you think about your illness, how much do you think you control what happens? Ask about how they view their disease process using their spiritual lens. How do you make sense of your illness? How do you see God through your illness? What would a miracle look like to you? And what do you think God's will is for you? Praying for a miracle. I think we've all heard this once or twice in our practice, but I think it's important that we be present in our patients' miracles and try not to challenge their views. It's not our jobs to make our patients understand or realize that they're dying. It's our job to ease their suffering. The miracle for them might be that they die peacefully and get to go to heaven. For my uncle, our family's miracle was that he accepted Jesus Christ as a Savior and would go to heaven. Join in their hoping, because this has a huge impact on how they feel with your interaction with them. Culture facilitates and impacts how patients make meaning of their illness, respond to symptoms, and make decisions about healthcare choices, and express affect related to the dying process. Back to the case. What are the barriers and values that were involved? For my uncle, mistrust was something that my cousin felt. She felt that the team had their own agenda. And health literacy also had a huge impact in how things went along at his end of life. Socioeconomic situation where he was taking care of his daughter and there was no one else to take care of him. But the values that I see here were spirituality and familism, where my family would go to his house at the end, the days leading up to his hospitalization, and would bring the guitar and the guiro and sing coritos or common spiritual songs, and they would pray with him. So, ¿qué podemos hacer? What can we do for all of our patients? I want you to understand that this talk is not just for Latinos, but it's for all of our patients who come from a different background. What practice tools or strategies can we incorporate when we take care of our patients? In one study that showed, that looked at best practices by palliative care clinicians, showed that meeting with interpreters before and after had a huge impact on how discussions went, just to clarify the agenda and to debrief with interpreters to provide support and improve interpreter and clinician satisfaction. The number of Hispanic healthcare professionals also do not mirror the total percentage of Hispanics in the USA. Hispanic professionals have been historically underrepresented in the health professionals. For that reason, I propose that we should be involving more Spanish or cultural congruent providers. And one study that looked at Latinos and their perceptions of their healthcare providers showed that they wanted a clinician who showed respect and attentiveness during the interaction. Unlike European Americans and many African Americans, most Latinos preferred an ethnic or language concordant provider. Some didn't have a preference for ethnic concordant provider as long as the provider knew Spanish, while others preferred a Latino provider, believing that Latino providers would understand the culture and their experiences. I think it's also important that we have culturally appropriate educational materials and navigation tools. There were 2 studies done, Prepare for Your Care, which is an easy-to-read advanced directive online that's interactive, which resulted in higher advanced care planning, documentation, and engagement, which was very effective with English and Spanish speakers with limited health literacy. But most importantly, what I want you all to take away is the need for cultural humility, a curiosity and genuine interest to do good by all of our patients. Now, to conclude, after receiving all of this information regarding values, how do I explain palliative care to my Latino patients? And I tell you all that you would explain it as you would to any other patient, but keeping all these cultural considerations in mind. Use a translator, even if their English is quite well, but if they don't feel comfortable, it might be helpful to include an interpreter. Speak to the family in a group setting. Use warm and verbal and nonverbal communication skills to let patients know what palliative care is, as an extra layer of support designed to help them through their illness, and here to help with symptom management and decision making. Thank you.
Leslie, thank you for such a fantastic talk to help us explore and hopefully combat our unconscious biases. Want to open it up for any preguntas?
No questions?
That was wonderful. Thank you. I've worked with many Latino families where either the patient or another significant family member did not speak English, but other family members did and wanted to translate. And I became aware, I speak very little Spanish, but I became aware that not all the things I was saying were going through to the patient, either because the person translating wanted to protect them from bad news or didn't understand quite how important that particular issue was that I was trying to explain, or whatever. I don't know the reasons all the time. Do you have any advice how to bring in a professional interpreter when there is a family member who says, oh, no problem, I can translate?
Yeah. So a few things that we can do is ask the patient, is it okay that we include an interpreter? I think it's important that the value of dignity and not wanting to put the burden on their family members. I think identifying that and saying, gosh, you're doing already so much for your family member, and I really want you and the patient to understand what's going on, and also just making sure that's okay with the patient. I mean, we've all encountered these situations, and then we're also thinking about confianza or trust. You want to develop that rapport. So it depends on the situation. Sometimes you have to, it's the risk versus benefit. Like, am I going to break trust just because, the family feels strongly? But I think it's important that we try our best and just kind of relieving that burden from the family member and just advocating that I really want to do what's best for you and I really want you to understand. So that's what I would say.
Other questions?
Lovely presentation. Not a question, just a comment. And that is, I was lucky enough to be a participant in the room in the patient that you referenced. And to see this gentleman open up when you could just ask, how are you doing in Spanish for a moment, it was beautiful and it opened the room.
Thank you.
Thank you.
Thank you.
I'll open it up for any questions at our remote sites. Silence from our remote site.
Can you hear me?
Oh, yes, we can,
Yeah.
Ricky.
Yeah, thanks. Leslie, it's Ricky Leader. Beautiful talk. I wonder, based on your, personal and I guess professional experiences through this year and even before, do you think it's a matter of adapting the communication structures we already have in place in palliative care to better serve our patients, or do we really need to think differently about how we approach serious illness conversations with patients from different cultures, I guess specifically Latinos?
So I think the communication skills that we learn in palliative care are essential, and you can see them woven in this talk, especially with, asking questions about spirituality or how they view their illness in their own language. But I do think it's important that we receive training on cultural competence and sensitivity and humility. Because even though, as I mentioned, we're not all the same, it's important to understand what common trends and values and barriers that patients are facing so that we can, plan our care accordingly. So I do think it's important that we receive training in other ways to be able to provide culturally coordinate care to our patients.
Other questions remotely or here? Well, we'll end there. Thank you, Leslie.
Thank you.